Nuestra siguiente participante para cerrar la sesión de conferencias de esta tarde es Anya Pacholczyk. Espero que lo haya pronunciado bien.
Yes, very well.
Que nos hablará de las células troncales y Deep Brain Stimulation. ¿Cómo lo traduzco? Anya es estudiante candidata a doctora en bioética por el Instituto para la Ciencia, Ética e Innovación de la Universidad de Manchester. Tiene una licenciatura en Ciencias Cognitivas de la Universidad de Westminster en el Reino Unido. Cursó su maestría en bioética, ética y derecho por la Universidad de Manchester, donde ahora estudia su doctorado. Bienvenida, Anya.
Thank you, Maria, for the kind introduction. Good evening, everyone. I'm the last speaker, so I hope to keep you entertained while still providing something of content. So as Maria said, my background is in science, and then I had some questions which can't be easily answered by my professors, and so I went to study ethics. The question that sprang in my mind when I was studying cognitive science was why there are so many restrictions on science. This was one of the main questions I had, and I knew that there is all this regulation around, and I didn't quite understand the context. I just knew that I should adhere to the regulations. And so I went on to ask those questions. Now I write a lot about the philosophical issues. I'm very interested in issues of our understanding of our use of technology, so from a more philosophical standpoint. But recently I became interested in deep brain stimulation as an example of an innovative procedure. And that interest kind of brought me back to my original question about ethical guidelines and about regulation. And so today I would like to take the example of deep brain stimulation and look at how ethical guidelines developed and also what is missing from those ethical guidelines and what kind of lessons that can provide for us when we are talking about stem cells. So firstly, a couple of words about ethical guidelines. So they are developed to inform practice and to foster ethical actions. And typically they are not legally binding. And so quite often then they impose higher ethical standards than the law does. Many professional associations and organizations develop ethical guidelines, and sometimes there's some teeth to them. That is, they can be enforced and by disciplinary actions of the professional association. They typically distill ethical issues and offer recommendations for action, so they're kind of ethical considerations simplified for application in practice. They can also be used as a beginning of talking about regulation. So I'd like to consider the ethical regulations developed for deep brain stimulation, but let me talk briefly about deep brain stimulation first. And so in deep brain stimulation, you have the patient has electrodes implanted deep in their brain in order to get alleviation of symptoms of whatever disease DBS is aimed to treat. By now, over 70,000 of patients receive DBS worldwide, although those estimations are a little bit difficult because there is no single database that would encompass all the clinical trials and the result and the adverse events and all the patients. So perhaps that raises an interesting question of how the data can be pulled together in order for us to be able to make more informed choices both about regulation and ethical guidelines. And so the FDA approved DBS for essential tremor, Parkinson's disease in dystonia. They considered approving it for epilepsy, but despite pretty good evidence, they decided not to approve it yet. There are also many new applications under investigation, and that includes DBS for depression, that includes DBS for bipolar disorder, and I think most notably for obsessive-compulsive disorder. And currently the treatment for obsessive-compulsive disorder happens under the humanitarian device exemption, which brings its own problems. I do not have time to talk about it now here, but it brings its own problems. And so in DBS, just to give you an idea what the whole DBS system involves, because it's relevant for risks, you have the deep brain stimulation. Oops, I broke it. How do I make it shine? Okay, thank you. So you have the deep brain stimulation lead, which is a wire inserted inside of the brain. And at the end of it, there are some electrodes that aim to provide the stimulation. This picture particularly shows DBS for Parkinson's disease. The substantia nigra is the part of the brain that's affected in Parkinson's, and subthalamic nucleus is one of the two main targets of the stimulation. And so even for Parkinson's, there are several targets. For other diseases also there are several targets, and there's a lot of discussion about which kind of targets are more appropriate. And that is the case even for Parkinson's, although the treatment for Parkinson's have been going on for more than 20 years. The lead and the electrodes are connected by the wire to the battery, which is implanted under the skin, as we'll see on the picture soon. And I think it's important to keep that scheme in mind for the considerations of risks a little bit later. So this image shows the procedure, the implantation procedure. The patient is usually asleep during the first part, and then the patient is awake to be able to adjust the stimulation. Here we can see a procedure, the DBS procedure for essential tremor of a Los Angeles-based actor and comedian who also was a performer and developed essential tremor, so couldn't play guitar anymore, underwent DBS. And so this is the UCL, I think, team, and the patient is awake, and they're testing how much improvement there is while he's playing the guitar. If you'd like to follow that, they actually published several tweets of the procedure. It's, I think, a 500th procedure of that team, but they decided to publicize it in order to make the patients who consider DBS a little bit more familiar with what that would involve. So this is the battery. As you remember, there is a lead going through the body to the battery. And usually it does not look like this. This is in someone who is very, very skinny. And so it's more visible. So usually it's a little bit more like that. And this procedure of implantation of the battery is usually performed a little bit later, a couple of weeks later. So to let the patient rest after the massive brain surgery that has a lot of risks coming with it. And then a couple of weeks later, the battery is implanted. And I think actually knowing how DBS, the whole system, is important because, for example, there are ethical issues arising from clinical trials that are halted because of whatever reason, while some patients experience benefit and they want to keep the DBS. But then the batteries have to be replaced, and each battery costs several £1,000s. So then the question is there a responsibility of the investigators to make the treatment until the patient doesn't want it? Or whether halting of a clinical trial is the end of the obligation? And this is actually a problem that I have found out about from talking with neurosurgeons and talking with patients. And so several times during my visits for other conferences, I would set up meetings and talk with people to identify the kind of issues that I cannot think about. So all that I'm talking about today comes from a literature review. My papers about ethics of DBS, which are usually more philosophically oriented, and also informal interviews with stakeholders. So in terms of surgery and device-related risks, they're pretty well established. We pretty much well know what the ratio is. They differ pretty highly, as you can see. There is a pretty much big range. And probably quite a lot of this range is due to the expertise of the team. So here there is another issue arising about the necessity of training, but also what to do if there is a team that is only starting and they have to learn somehow, and they cannot have always a top neurosurgeon standing behind them because it's very expensive, difficult to organize, and so on. But then can we advise the patient? Can we refer the patient to the team that we know is not that good? So those risks, I think we can see that there are quite high risks of pretty serious adverse events. One thing that is not really specified here is also a risk of brain damage, and the risk is just in terms of inserting the lead, there will be a small brain damage. And of course, in many cases it may mean not very much, but sometimes it may have a great impact. That's another point I wanted to, so if you remember how DBS system looks like, you can see that problems to do with the lead, so the wire that goes inside and has electrodes on the end of it, is quite a big problem. And so actually cooperating with the industry to develop better quality equipment is quite important in the interest of patients. But of course, those risks are not the only risks. There are also risks of adverse events associated directly with the treatment. And there is a very rich ethical literature around DBS generally. In the last 10 years, I think it boomed quite a lot, but there is still many issues that are still developing, coming up, such as, for example, the attitude of patients towards having something implanted into them, and then ascription of causality and then responsibility, the issues of autonomy and freedom. In Parkinson's disease, one of the common, I think around 5% of patients experience mania. But also there can be personality changes related to DBS, and so when the stimulation is stopped, those effects disappear. However, patients may have preferences. They may prefer to be in the manic state because it feels good. And so there's also a question of power between the physicians and the patients, with physicians having their own idea of what is the best outcome, and patients having their own idea about what is the best outcome. And so that particular problem can be then extended to refer to philosophical concepts, philosophical explanations of concepts such as autonomy. There are also issues about consent, and I think those issues are becoming more and more prominent in the DBS discussion because of the proposals for new applications for disorders such as depression. So there is a very rich literature on consent as well. So far, DBS has been largely, there are some exceptions, but not many, applied for adults who are able to consent. So then there is also an issue if it is a treatment judged as effective and safe enough for some cases, why not to try help patients who are not able to consent, or children? And I think with children, the case that really broke me is cases of kids who have very strong muscular tics. And so if the DBS is, and they are not responsive to other medication well enough, and so if DBS is not performed early, that can have a lasting damage, which cannot be reversed then. Yet, everyone is very uneasy about applying brain stimulation to kids. There are also issues about appropriate patient selection, and that whole discussion links back to the issues of psychosurgery. And also the issues of identity and narrative identity, also social roles and psychosocial adjustment of patients. And there has been a paper published arguing that although physicians sometimes may be very happy with the treatment, with the outcomes of treatment, the patients may not be as happy. The motor symptoms might have disappeared, but now I feel I'm someone else. So those issues, I think, are not thoroughly explored, and I will have a chapter in the new Springer Handbook of Neuroethics addressing largely this issue coming up. There's also a worry about potentially unethical uses, such as military uses and social control, and although we can think about them as being very speculative because DBS is very much in the clinical box currently. But then we think back to the 60s and to the experiments of Delgado, for example. And so those worries, I think, spring back again. And I also think that actually there is a point to those worries and we shouldn't just put them aside and brush them aside, especially if we think about countries with not that strong tradition of regulation. So I think one example of that, so DBS is completely not indicated for schizophrenia, while there are reports that there are single cases of applying DBS for schizophrenia in China. It's just a real issue. So the history of psychosurgery influences very, very strongly the current ethical debate. And sometimes very annoying because it seems like we cannot really get through that, past that, and pay attention to what is important now. But I think at the same time, it actually makes this ethical discussion present very extensive. So there are bad and good consequences of referring to the history of psychosurgery, and I think that it's maybe a little bit similar. There is an analogy here with stem cells and talking about embryos. So perhaps the problematic aspect, the huge controversy, could also provide that push to consider other ethical issues. And so as I said, DBS is pretty much accepted for movement disorders. It seems not very problematic. There are specifics, patient selection, the right target, and so on and so forth, but generally accepted. Neuropsychiatric disorders, not really. So there is a lot of controversy with some people saying, yes, we really should do that, those patients are really suffering, and some saying, no, this is the first step on the slippery slope, or it's not indicated yet, we have to proceed very slowly. There is a lot of controversy. And there, I think, is pretty much a consensus that this is wrong. The DBS for those things is wrong. And I, as a scholar, am really interested in the ethics of enhancement, and I have argued extensively that we have a little bit of an anti-enhancement bias. And especially in case of DBS, I think, illustrates very, very well how ethical guidelines, which say DBS for enhancement is wrong, shouldn't be performed, are very stiff. And so they don't allow those other cases, which are a little bit, I think, more ambiguous to say the least, and also simplify the issue with consequences such as that actual important factors are not considered. And to give you an example, my favorite one is a neuroscientist who would like to have a DBS implanted to experiment with themselves. And so they are not expecting a benefit, except for that wide benefit of being able to do that. They would like to try things out. So really the consideration, this blank saying this is just wrong, does not apply here. Of course, we can talk about, well, neurosurgeons have more important things to do than do that. They are patients there. It's very expensive. But all right, if they were willing to pay and promised very hard that they're going to be a very rigorous experimentation done, and so there's going to be something good coming out of it in terms of the science. Well, at least there is something to think about there. So the blank saying no, I don't think applies. And those are ethical issues identified by healthcare providers, for those on the ground. And I think it's important to remember from whose point of view we are looking at issues, and also for whom we want to develop the guidelines. And so those are the issues, the issues identified by healthcare providers. And I think this shows actually how important it is to involve different stakeholders, because those issues have not been discussed as much in the ethical literature. There are some empirical studies that also talk about attitudes of neurosurgeons and the public generally and patients, but they are not very extensive. I think there is definitely a space for doing more. So in terms of the explicit ethical guidelines in DBS, recently there has been a review performed by Bell and Racine from Montreal, and I think they did a very, very good job, because the ethical guidelines really proliferated. And there is some consensus and some overlap, some differences, and so putting it all together, I think, was a very, very good job. And that shows us, for example, from how many different sources those guidelines come. And I think it's important also to remember that each of the groups and each of us will come to the discussion about ethics from a little bit different point of view and have something to contribute. So Bell and Racine identified 7 major themes of the guidelines. So there are issues of ethical oversight. Generally, there's a consensus that some kind of formal, independent ethical oversight should be there for every single case where DBS is performed. Of course, the realities differ a little bit. So there's a problem with the humanitarian device exemptions, for example. There's a little bit of medical tourism going on in terms of DBS as well. But at least the ethical guidelines say there's no compromise on that. And I think it demonstrates just how careful the community is not to evoke too much controversy and to make sure that there is this sphere of ethics around DBS. They also emphasized very strongly the importance of experience and interdisciplinary teams, including psychiatrists and psychologists, and the importance of patient selection. And I think those 3 actually demonstrate very well how strong the influence of the history of psychosurgery was, because the problems that occurred there are being tried to be addressed by those things. There are also the obligations to research subjects, and also talking about informed consent a lot, social responsibilities. I don't want to spend too much time on this. I could talk about each single point for a while. Please ask me after the talk if you're interested. So what I want to focus on is what has not been addressed, or has been addressed just a little. How much time do I have?
Yes, 15 minutes.
15 minutes, okay. So the issues that haven't been addressed in great detail or effectively was fair access to DBS, allocation of resources and funding, and this is there was also the issue of power and control that I mentioned, whose idea of what are the right settings for the stimulation should prevail. The physicians who have the duty of care, or the patients who may have their own idea. There's also an issue about being in control of the settings of the stimulation after the whole process of adjusting the settings has finished. So there are some stimulators where, because usually patients have only control to switch it off or on. And some patients utilize it because, for example, they cannot sleep comfortably if it's on, or they cannot talk very well if it's on, but they can walk. But if they want to talk, they have to switch it off. But there are also devices where perhaps there can be a couple of settings. And so then the question arises, should we allow patients to decide what mood to be in? So if they receive DBS for depression, they can have I'm all right setting, and then I'm in a party mood setting. So should we allow patients to make those kinds of decisions or not? And generally neurosurgeons say, well, this is not really, I think we know best. And there's some research on whether patients control very little, whether patient control of the settings leads to bad outcomes, and the research generally says probably not, rather not. Yet there is still a lot of hesitance to ground that control. While the technology is developing, and more devices will probably offer that possibility. There are also issues around the reversibility of Dbs, with many people saying, well, you can just stop the stimulation. Well, yes, perhaps, but then some of the changes induced by the stimulation may actually linger. So we don't actually know yet to which extent Dbs is reversible, while mostly it's marketed to us as a reversible procedure. Also, one of the things that I'm actually pretty worried about is the data about unwanted effects and specific kind of unwanted effects. Those to do with personality, those to do with more subjective patient experience of things, because those adverse effects or unwanted effects are so difficult to measure. They're not really measured. There's not that much attempt to measure them as well, and so that means that there's, I think, a whole spectrum of a whole group of those effects that are not reported properly, and those actually are the ones that are so important for the patients. And that also applies to treatment evaluation, and so I think that issue of patient's perspective is going to come up more and more in the discussions. There is also an issue of medical tourism, which is not very extensive, just because the procedure is so expensive. But I think it's rising. I did a quick search, and there are several places in Thailand, for example, that are offering Dbs. So this is an issue that is not addressed that much. There is also the ethics of providing Dbs for enhancement, and I talked about patients before. So I wanted to focus just on one to give examples of how those issues can unravel. So for example, Dbs includes lengthy follow-up. So after the procedure finished and patients are well and good, they have to come back every 2 weeks, every month, to adjust the settings a little bit better, and a little bit better. And so that means that it's very personalized and that the outcomes are better. However, that also means that patients sometimes travel through half of the state to see their care provider. And this is a serious problem for some, and I think that this is not particularly emphasized in consent forms, while some of the patients have to be ready to turn their lives around, to be able to adapt of what the treatment, effective treatment, requires of them in terms of adaptation. There is also the issue of the maintenance of the device. I talked about exchanging the battery. Also, patients' motivations and life situation may influence the way they see their risk, and so the current guidelines are pretty inflexible. They, I think, put the assessment of the risk in the hands of physician mainly. There are also very strong interpersonal challenges faced after Dbs. So disruptions of identity, but also problems with relating to spouses. So it's very there is a very strong data showing that patients after undergoing Dbs for Parkinson's quite often experience crisis in their marriages after, because the roles have shifted. If they are better, then maybe they shouldn't just linger there. They can do something more. Maybe the spouse expects them to do more, where they're happy in the role of the ill. Or maybe the opposite happened. The spouse sees them as the one that needs care, while they're all happy to travel around the world now. And both of those changes in dynamic happen, and there is some little empirical research that exactly shows what kind of problems can arise. And I don't think patients realize that such a massive shift, and with DBS it occurs pretty quickly, can mean a disruption as well and require adaptation. And so perhaps also a question there is, would there be a merit in providing psychotherapy to help adjustment? How am I doing with time? Okay, in that case, I'm going to go very quick. And so I think all those mentioned issues influence the way we should judge how good the outcome of the treatment was. However, they are not very well considered. And so when we were talking about developing ethical regulations and also ethical guidelines, I think there are several questions we are faced with. And one is the efforts at making it context-specific versus the charge of just reinventing the wheel again and again and again. I mean, many of those issues have been already addressed in the context of clinical research. I personally do think that there is a very big merit in actually making it issue specific, and I think the case of DBS shows that with specific problems arising for the stimulation, which does not arise in the other contexts. There's a question of how much attention we want to put on bringing the evidence-based ethics in on all stages of developing and evaluating our guidelines. We also have to think very carefully what is the goal of our ethical guidelines, and for whom do we want those ethical guidelines to be developed, and also do we think about this as a first step towards the regulation or the end goal. And I think the outcome in terms of what ethical guidelines say may be a little bit different depending on our answer. I will skip this, and so my general conclusions are that it's very important to involve patients and patients' associations. And usually, even though last years have brought a little bit of a push towards doing that, it still doesn't happen to the extent I think it should. It's very important to collect patient-focused data about the results of treatments, about side effects, and talk about quality of life, and perhaps explore patients' understanding a little bit more. So this is in terms of being patient-oriented. That's my mantra. But there are also other issues. So firstly, the target audience is very important. But also, I think from DBS, the consent in DBS is very highly regulated, sometimes word by word. There's no evidence that that's strong regulation, so prescribing word by word formulation helps anything. So we can over-regulate as well. So I think we have to remember that now perhaps there's not enough regulation, so we may get a little bit over-eager. So let's remember that we can go a little bit overboard too with that. I mentioned the balance between the context-specific approaches and utilizing the regulations that are already there. Considering the role of pragmatic neuroethics. One thing that was really annoying me when I was reading ethical guidelines for DBS is that the rationale is not made explicit. So we are here presented with the product, but there's no way to engage with it, because we don't know what the reasons are. And sometimes they are, for example, connected to risks. And I gave you an example of the neuroscientist who wants to have a DBS, when the reasons don't apply, and then the guideline is inappropriate. And I think it's important when we develop the guidelines to also show how we got there. We also cannot think that the challenges are not going to change. And I think in DBS you have a little bit of caution visible in regulations. And so it's a little bit stiff. It's a little bit stiff. So let's think to be flexible. Those are the International Society for Stem Cell Research regulations, and so have a look on the website to see where the regulation is at. I think There's a little bit about medical tourism that is developed there. Those guidelines are developed to apply generally. So I think there's a merit to create context-specific for Mexico guidelines. And since I'm the last speaker, before we part, I would like to ask you to consider this general question. So why are you here? I was thinking about it myself. Why am I here? What can I contribute? There are so many reasons, so many approaches, so many stances from which we can come to talk about ethics of stem cells. And so I think knowing explicitly what is important for us, I think it's important. And so there are so many options here. Well, I realized that my goal, to a little bit of my surprise, I have to say, because I always saw myself as a philosopher, but my real motivation is to facilitate development of science, but make sure that the science is used for the good and is applied. But I also want to facilitate patients' autonomous choices about their lives, and I think that includes an active and empowered stance towards management of their illness. So what are your reasons? To finish with something that will show the reasons I am here. This is a TED Talk I came across some time ago. And Jamie Haywood developed a website in which patients can input their data about their illness. And initially he did it to be able to see what works and doesn't for his own brother who developed ALS. But there's several tens of thousands of patients on that website now. And perhaps this may be a good and not conventional way of getting some data when otherwise it's impossible to get any data. So Sarah talked about those provisions of treatments that are unregulated. Well, currently patients are getting those treatments. Currently there are no way of tracking those patients. Isn't that a quick way, maybe in-between way, to try to get something where there's nothing now? And so I encourage you to look at the TED Talk. And thank you very much. And I'm looking forward to seeing you over the next 2 days.
Muchas gracias, Anya, por tu brillante exposición. No nos queda tiempo para preguntas y respuestas, pero si hay alguna breve. ¿No? ¿Sí?
I wonder why the batteries are planted inside the body of the patient. Is it for them not to take them out, or just for security reasons?
I think it's for security reasons, because the cable that connects can very easily get disattached. And so also I think patients prefer not to have cables sticking out of their heads. And so it's placed underneath the skin with the battery being able to be carried, without any extra problem. I think that's the rationale.
Muchas gracias, Anya. A Anya la tendrán los 3 días también dirigiendo los workshops, los talleres al final.